This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson, and it's my pleasure to have with us tonight Dr. James Cunningham. Welcome, Jim.
Thank you very much for inviting me.
Well, it's great to have you here. So tonight, maybe we can talk about some of your adventures in life and how you came to your present position as the medical director at the Medical Center of Central Georgia.
How far back in life do you want
well,
me to go? Well,
we could start. I mean, we could start a little bit about just your general medical training and how that happened, and you.
Well, I went to medical school at the University of Tennessee, and then went into general surgery. Did a general surgery residency, and actually did general surgery for a short period of time before I realized I really wanted to do heart surgery.
Yes.
So I went out to the University of Southern California and took the thoracic and cardiovascular training out there, and actually did heart surgery for about 23 years.
Wow. So you really had a lot
Right.
of clinical exposure, and you've been in the OR. You've been right there in the middle of lots
yes,
of intense situations.
But about 9 years ago, thought I would want to do something just a little different.
Yes,
Not that I didn't like heart surgery.
Right, yes.
Went up to the University of Pittsburgh
Yes.
and took training in trauma and surgical critical care.
Yes.
And that's how I ended up down at the medical center. I knew Dr. Dennis Ashley, who I
Yes,
think has
right.
been on your program
Yes,
some.
he has. Yes, he has. Yes.
And wanted to build up the intensivist program, the trauma surgery program there. And from 2004 to 2008,
Yes.
I was the director of the cardiovascular intensive care unit.
Yes, yes.
But also took trauma surgery call
Yes.
and worked in that ICU.
yes.
And then in 2008, had a life-changing experience for me.
Dare you say what the life-changing experience was?
Well, my predecessor in the job of chief medical officer
Yes.
decided to retire.
Yes.
And you know the old adage in life, be careful what you ask for because it may come true.
Oh, and so you
So I applied for that, and because I thought that with my clinical experience, you know, I probably could be an asset to the medical
Yes,
center in
yes,
that role of chief
yes,
medical
yes.
officer. So did get the position, so I have been doing that for the last 4 years, since Cinco de Mayo of 2008.
Oh, good. So
So I'm coming up that 4th year
All right, well,
anniversary.
that's a good story.
Yes.
And actually, if I can recollect this, I believe you have boards in a number of specialties. Is that correct?
Board certified in general surgery,
Yes.
thoracic surgery, and surgical critical
Wow,
care.
so
Yes.
you're triple boarded.
That
sounds
sounds good, doesn't it?
It does sound good. Why don't you say what boards are? I mean, what does that mean when you
Well,
actually...
boards, when you finish a residency or sometimes a fellowship, which
Yes.
is an extra year or two of training after a residency,
Yes.
there are certain organizations, and one of these is the American Board of Surgery. And the American Board of Surgery basically says, well, let's see how you
Yes.
know as far as your book knowledge,
Yes.
but then there's an oral exam also
Yes.
that you take. And if you pass that, you are considered boarded by the
Yes,
American,
yes, yes.
American Board of Surgery.
Yes.
And then, of course, there's an American Board of Thoracic Surgery.
Yes.
And for me, I did take that extra training in surgical critical
Yes,
care.
yes.
And so that was just basically a written test to show
Yes.
that I had the basic knowledge for surgical critical care. And I have continued to use that really since I took this position of CMO in May of 2008.
Yes.
I've tried to continue working in the ICUs, and so what I've done is I spend about 75% of my time in this role as CMO,
Yes.
but for 1 week a month,
Yes.
I do go down to the surgical trauma intensive care unit and the attending physician down there, the attending
Yes,
intensivist,
yes.
and still take some trauma call.
Yes.
You know, I'll work a 24-hour shift on a Saturday a couple times a month, depends upon what the schedule's like.
So
I try to stay clinically active is what I'm saying.
And so one of the things to discuss, but we can chat about that a little bit, is the interface that happens between practicing physicians and a large hospital, and how that occurs, and some of the role you play in some of your responsibilities, and in many ways looking after the public interest in your job. What exactly does that entail? I think there are about 500 physicians or so.
550.
That's a lot of docs. There are 550 docs.
Well, we have
on the medical centers.
Well, the medical center, there's 637 beds. We've got 87 critical care beds now, 5,000 employees.
Yes.
550 physicians.
Yes.
And in my role as CMO, I have 3 individuals that I rely on to report to me.
Yes.
One is our chief academic officer.
Yes.
And she kind of takes care of the residents, but also and the medical students, things like this, as far as making sure things are going right for them.
Right.
But she also is our chief quality officer, and that's Dr. Marcy Hutchinson.
Yes.
We have a new...
Well, now, what is a quality officer? What exactly? Maybe you can chat about that. What does a quality officer do, and how are the public interests protected, and how is the system functioning now?
Well, I think if you ask me, if you are a patient coming to our hospital, you would want quality. You would say, I want a quality experience here. I want to make sure I get quality care. So what some of these outside organizations, such as the Joint Commission, the Centers for Medicare and Medicaid Services, they have certain metrics that they want us to live up to, and we want to do this. Obviously, we want to do what's best for the patient. But the quality officer basically, we have people working in the quality department. There are individuals down there that abstract data. There are individuals that go around and just to make sure certain things are being done. For instance, if you were to come into the hospital and we're going to have an operation, one of the things that we would want to make sure is certain protections are issued to you, such as to make sure you don't get a blood clot in your legs. So we would have to have certain devices put on there, certain medications, and these are the things that the quality department is looking at to make sure our practicing physicians, as well as the nursing staff, are doing. That's just one aspect, just to make sure there's these certain devices are put on, certain medications given for that.
Yes, occasionally I've made reference to excessive government regulation, excessive, oversight. Nevertheless, I mean, these have been very useful efforts that have occurred over the years to improve patient quality, better outcomes, and so these are being mandated fairly routinely.
These are being measured, and these are what they call the quality metrics. In other words, there are certain things that are being measured. Did you get the right antibiotic when you had your operation? You come in with a heart attack. Did you get the right medications? And this is what we call evidence-based medicine. In other words, the institutions around the country do certain things, and there is data that has come out that says if you do A, you should get a good outcome. But that's probably, Dr. Robinson, what's going to happen. It's not so much the measurement. These are important, but what we want to make sure is we get the right outcome. Are these the right metrics to look at to assure that you come in, have a good experience, and get out of the hospital? Nothing bad happens to you while you're in the hospital.
There was a
that's very important.
That's right, it is. And there was a rather inflammatory report that came out a year or two ago from the Institute of Medicine about the extraordinary number of misadventures that occurred in a hospital setting. I mean, do you have a comment about that? There's a big effort underway to sort of prevent any disaster from occurring, and there are things called, I guess, incident reports, and there's sentinel events. And
there's all sorts of things.
What is that? What is
probably, and again, there's incidents that do occur. And I think most of us feel that that's probably the tip of the iceberg. Now, major things that happen, an individual comes in that has an unexpected death or a major reaction to something. These things are reported, and we know about those, but there's probably other little things that do occur. Maybe a missed medication that there's no adverse outcome, something like that. But these major events that occur, then the quality office and ultimately up to me, we look into that. We have to find out what happened. We have really tried to do what we call a just culture. In other words, if something happens, we don't, you messed up, blah, blah. We don't want to do that. We want to find out what happened. What can we do unless you did something deliberately? Now, if you did it deliberately, different story. But we try not to play the blame game. We want people to be free to report things that occur. And if they do, what can we do to make sure that does not happen again?
So this is an important thing in the American healthcare system. The idea, it's a little bit like systems engineering. But we have, when a patient enters a hospital, we want the appropriate events to occur. We want the indications to have whatever kind of therapeutic manipulations occur. We want those to be correct. We don't want any complications. We want a good outcome. And the system, there are a lot of people working around the clock to make sure that happens. Is that correct? And I mean, so the public interest is substantially protected, or there's an effort to do that.
And when you think about it, the medical system in the past, you know, and we've changed this, and I think we've made really good progress on changing some of this. But if you look at the airline industry, think about that. You know, not that many years ago, the captain, the pilot, he was in charge. Nobody had anything to say about that. But now, everybody is responsible before that plane leaves the gate. But the hospitals have been kind of reluctant to do that. But now we realize that a patient's safety, which is obviously very important, everybody has to be involved with that from the time the patient comes into the hospital. Say they're going to have an operation. You got to make sure you're doing the right operation on the right patient, the right side. You know that's your surgeon. You go in there and you have to go through the maneuvers to make sure that what you're doing is on the right patient. And it's very important to do that.
You know, I can say that, absolutely, and I can say that the public's interest, there are big efforts to make things better and better in the healthcare system, and lots of efforts underway. More so than I would say most countries. I don't know. Can you compare our quality assurance issue with anywhere else? I mean, have any thoughts about that?
Well,
it seems to be pretty high in the States.
I can go back to the surgery, because you and I are surgeons, and of course the World Health Organization does have what they call a surgical checklist. It's a very extensive list that you go through before the patient comes in the operating room, in the operating room, and afterwards. Now, in this country, most hospitals, including the Medical Center of Central Georgia, we do have that checklist. We may not have every detail that's on that World Health Organization checklist, but we are pretty darn close. And so there are standards around the world. We are obviously adopting them, but there's things that we do that people around the world are also adopting too.
You know, I think some of this came from Boston, am I correct? I mean, so
a lot comes from Boston and from the John Hopkins and all that stuff.
Well, that's right. So lots of interchanges underway to make things better and better. Well, now, you've mentioned 3 people that report to you. That was...
I only gave you one.
All right, so you have 2 more to talk about,
Well, we also have the Chief Medical Information Officer, and that is Dr. Delanor Doyle. And I think most of your viewers realize that we are definitely in the computer age. And so one of the things that we are going to have to move to, and some of this has been mandated by the government, is this ability to communicate between the hospital, doctor's offices, other hospitals, and this is that continuity of care document. In other words, if you were admitted to the Medical Center of Central Georgia, but say you're up in Augusta. Well, you know, how do they know what's going on? So now we are establishing that communication, very secure, so people can't tap into this and get your medical information. But now if you're admitted up there, get on the computer and find out your medical history so they're not repeating tests, doing things like this. The other thing that Dr. Doyle is very involved with is what we call computerized provider order entry, CPOE. In other words, right now, you come in and you do it all the time. Or your extender or whatever, you're writing orders, you know, and the nurse looks at them, and then they go on. Well, there's that chance, you know, that not that for you, of course, you would write very clearly.
Of course. Excellent handwriting.
Excellent,
I'm glad you know that.
Problem.
Good handwriting.
But for some individuals, and this is where mistakes can be made, but with the computer, you're on the computer, it's typed out, the pharmacy gets that, the dose is checked, the frequency, so the chance for error is diminished. So this is a big thing, and of course, it's a big change for physicians. Now physicians have got to be able to type this in. It's easier to do this, but they've got to learn. This is safer. It's patient safety.
So some of the doctors may have gone to handwriting camp in younger
I'm not
days,
sure too
or
many
maybe they should have gone handwriting camp.
They should have gone.
That's right. They should have gone handwriting.
Not you, though.
No, good. Yes, good. I'm glad you acknowledged.
Not me. We write.
Right. That's correct. Good. Well, so a lot of it's happening here, isn't it? I mean, the whole system is just racing ahead with on many fronts, and in the computer age, we're getting medical records squared away a lot better. So what this would mean, if I can understand this, is if we had a transfer that came from another hospital, then you could just push a button and all the test results from the other hospital would be there, all the patients' past medical records? Is that the idea?
Right, provided they are in sync with our system. You know, the government eventually wants this to be nationwide,
isn't that
but
a little,
right now we're trying to do this just for the state of Georgia, and we've got some hospitals lined up.
Now, isn't there a little complexity about that? Some hospitals are on a different kind of computer system, or the interfacing these computers, and so it's not as simple as it might seem at first
Again,
glance.
I'm not a computer whiz,
Yes.
so you're right.
Yes.
But you know, we've got a couple of systems. There's a couple of big name systems. One of them
Right.
is a Cerner system,
Yes.
and a lot of hospitals do use that. So obviously, that interface is
Right,
much easier
right.
if everybody's on the same
Yes.
thing. But you touched on a point. Some of the smaller hospitals, they may not really have some of the financial resources
Yes.
to do this. None of this is cheap. This
Right,
is very
right,
expensive,
right,
high-tech.
yes.
And so some of the bigger centers, and
Yes.
of course the Medical Center of Central Georgia
Right.
is one of those, we do have the financial resources to do that. So this is even more of an incentive for some of these smaller
Yes.
hub hospitals,
Yes.
you know, spokes, I'm sorry,
Yes.
to come in and link in with us. And we can provide some of that assistance because we've done a lot of this.
Well, now,
and it's going to be very important
Yes,
to do
yes.
that.
Now, isn't some of what you've touched on is sort of the arbitrary nature of the American healthcare system in a way, in that some hospitals just might not have much money and others might have more, and the people that I guess go to a hospital that's a bit underfunded, their situation may be a little more difficult, and they may be underfunded because of the insurance status of the people that patronize that hospital. Now, is that a fair statement? And that's a problem,
correct.
isn't it?
But see, they are still responsible for filling all of these mandates
Yes.
that the government says you've got to do
Yes.
this, you've got to do that. But then the resources may not be there. They just may not have the financial wherewithal to do that, and it puts them in a bind. And well,
Yes.
there are some concerns, and
Right,
you're
right,
well
yes,
aware of this,
yes,
I'm
yes,
sure,
yes.
that some of these smaller hospitals may actually have to close
Yes.
if they can't find some link to a larger medical center
Yes.
that help them out
Yes, yes.
in that.
Now-
But we want, listen, there's nothing wrong with the care at these hospitals.
yes.
It's so many of these ancillary services
Yes.
that they just don't have the money to provide.
Well, now you mentioned a rather explosive term, and that's government mandates. So one of the things that may be happening is if the government is saying you have to do this, you have to do that, and we have these standards that are being put in place, and if you're a well-capitalized hospital, it's not such a big problem to meet those standards. But the government gives no underfunded hospital any leeway. So I mean, and the people that need those hospitals often get a substantial nip from these mandates, and the government doesn't make any effort to fund these relatively poorly funded hospitals, do they? They say, here's some extra money, you need it, and they don't do that routinely.
That's the term, of course, that you mentioned is unfunded mandate. We
Yes.
expect you to do this, and it's up
Right.
to you to figure out
Right.
how to do it. And it's sort of like if they cut the reimbursement for
Yes,
Medicaid
right,
or
yes.
Medicare,
Right.
this is what we're going to pay you. Now you figure out
Right.
how you're going to live under these financial terms, and sometimes it's very difficult. Like you say, we have some leeway.
Right.
But for some of the smaller hospitals, you know, their margin may
right.
be very, very small, and it may make the difference between keeping a service open
Yes.
or even closing the doors. And it's bad because people they like to go to their
Right,
local
sure,
hospital.
sure.
Why would they want to have to travel somewhere else if that service can be
Right.
provided
And so
there?
now I think just to bounce the basketball a little bit on this subject, if the funding is cut by the government substantially with Medicare and Medicaid funding, any substantial cut, it will have a catastrophic impact on hospitals and just staying in business. And because of the extraordinary explosive and healthcare expenses, all the turmoil about funding these expenses, there's some vulnerabilities that are out there that are substantial. I mean, if for the medical center or any large hospital, if as has been threatened, and I think could happen, there's a substantial cut in Medicare funding, that would not only impact physicians, but impact hospitals and just their ability to keep their doors open.
Of course.
Is that a fair statement?
Of course. No, of course that's a fair statement.
And the other part of this are these mandates. And so we had a little discussion about some of the good mandates that are out there. But it could be possible, just to bring this point up, some of the mandates that might be put in there, well, they might be reasonable under some circumstances. You could say, well, we have extra fire extinguishers, or what, the stairs are particularly safe, or, I mean, all those things are to the good. But the risk, I guess the benefit, the cash benefit of doing this, it might not be what a prudent person would do. If you want to keep your hospital open, the government comes in and says the mandate is you have an extra fire extinguishers, that's all to the good. But if the question is those extra fire extinguishers and staying in business, it might not be prudent to require that. And what I'm getting at, do the hospitals have a chance to say these are not reasonable mandates? Do you ever say that back to the feds?
Is the term prudent mandate kind of an oxymoron when you're talking about the government or not?
Well, you know, I try and be nice to the government in the hopes they'll be nice to me. That's not always the case, but I mean,
Right.
you know, we all try and be nice to our government, but we need to tell the government when they're in error, when they are in error.
Right.
And you have any thoughts about that?
I think you know as well as I do that I think if you come to a hospital, if you come in, whatever you're coming in with, you don't expect anything bad to happen to you at the hospital.
Sure.
I mean, you may be very sick, but there's expectations that, hopefully there are expectations
and that's
that
what
you
we
will
all
get well.
are trying to
and
do
nothing
that.
bad,
Yeah,
you
sure,
won't get
sure,
the wrong
absolutely,
medicine,
right,
you won't fall
right,
out of bed,
yes, yes.
you know, you won't get the wrong
Right,
side
right, yes,
operated
yes,
on,
yes, yes.
all that. But I think the public needs to realize that nothing is going to be 100% safe. No
Yes.
matter what you do, there's some risk going to be
Right.
involved. And that's where you have to weigh, you know, the expense of giving this 100% protection to maybe, you know, you may
Right.
get up 99.9,
Right.
but the expense to get completely safe, it's sort of like the air traffic situation where you're going through the TSA,
Right,
you know,
right.
to make sure that nothing gets on the plane.
right.
You go through misery
Right,
to
right.
travel. I travel to Philadelphia
right.
and I'm miserable
Right,
because I got to
right.
do all this.
Now,
I have to strip down
I understand
practically to get on the plane.
it's a tough thing, yes.
But, you know, and there's some people that say that maybe, you know, you have to accept a little risk. But when it comes to the hospital,
Right.
that acceptable risk has to be very, very, very small,
Yes.
you know. But you've got to realize that there's going to be a human error no
Sure,
matter
sure,
what
sure.
happens. But we want to make sure that the physical plant, the processes that go on there, the chance for error is minimized, you know, as much as we
Yes,
can,
yes.
but we're all human beings.
Yes.
A mistake is going to be made, and
Right.
we just hope that those mistakes are very, very minor and they're picked up
Right,
right
right,
away.
right. And so I won't, maybe we could almost move on from this topic, but one final comment I'd like to make is one of the things that would be important is understanding the benefit that occurs from these expenditures. And the first question to be asked is, how much does it cost? How much of these mandates that the feds are putting in there? I mean, it's reasonable to do all of these things, but one of the things, isn't it hard to extract the actual cost of these mandates? So if we're going to have a discussion about minimizing risk, it's rather a difficult number to come up with. Is that a fair thing to say?
I think that's very fair. You know, if you say they're demanding certain of these innovations in information technology,
Yes.
well, we set aside millions
Yes.
of dollars every year just
Yes.
to make sure that we get the new stuff,
Right.
but also to upkeep the stuff you
Yes,
have. We
yes.
have to have
Right,
backup
sure,
systems,
sure.
and none of this, anything that goes to a hospital, as you know,
Right.
is very expensive. You get a bedpan, you could go somewhere, it may cost you $5.
Right, yes,
At the hospital,
right,
it's
yes,
$150.
yes,
I
yes.
mean, because it has to meet in certain standards. It's a bedpan. Does it make
Yes,
no?
yes.
But for the hospital, it's got to be this.
Yes,
you know,
yes.
there's just all sorts of restrictions and regulations.
Yes.
And believe me, Dr. Robinson, I think this is all very important. The question is, where is that cutoff where the dollars spent
Yes.
are not worth the possible
Yes,
risk?
yes. Well, my
And what
final
can I
comment
say?
is this, and we can move along, is when these mandates are hatched out, they're all great mandates, they're all good, but it would be unusual for the government to say this is what the mandates are actually going to cost when they configure the American healthcare system. And so one of the difficulties that are causing some of the crisis is these mandates are being put in with relatively little attention to what the cost is. And having the discussion that you've just embarked on, I think would be extremely important as we try and make things better. Well,
I think deep down, probably there is some recognition of the cost by these planners, but they're not going to publish it. That you
Yes,
don't. It's
yes,
very
yes,
difficult to
yes,
find that.
yes,
They just say,
yes.
"You need to do this."
Well,
okay?
we're
and then you
both,
find,
all right,
and
we're
then you
both, we're
have
both,
to figure out how to do
maybe
it.
as the government becomes nicer, we'll be able to extract this information. Maybe they'll have a change. They'll be very forthcoming and they'll be nice and tell us. But we'll see what we can do to prod them in that direction. But as we, yes,
I was just going to say one other thing, that I do have the 3 people that report, and the other individual is our Assistant Vice President of Medical Affairs. And this is where that whole credentialing of physicians, giving physicians privileges, and deciding if a physician does have a problem or something, I'm responsible, our office is responsible for checking into that. So we not only get complaints from patients directed at the hospital in general, but if a physician in particular, but also our office is making sure that if Dr. X says, I want to come to the medical center and practice there, we have to make sure that Dr. X has got the right credentials. We do not want to have somebody come there that is not who they say they are. And we have to follow that person along to make sure they are doing what they're supposed to do. Very important to do that, and our office is obviously responsible for that.
Yes, so one of the things that occurs when a patient comes to a large hospital like the medical center, all the physicians there are on the staff, their credentials have been checked, they're required pretty much to be board certified, to stay even with their boards, to continue postgraduate education. If there's anything that's substandard in either performance or any issues that come up, the hospital is watching that. So I think there's a lot of public protection that's underway. Would you say that? The public is well protected and diligently efforts to do that.
We have no choice because of the regulatory bodies, but the other thing is we would do that anyway.
Sure.
We would do that anyway. I would not want my mother or you wouldn't want one of your family members to come in if everybody's just kind of doing their thing and nobody's checking on it. So though it is very important to do that. We are in such a high-tech situation now where everything that is done is so critical. We cannot have any deviation from what I said earlier, and that's that evidence-based medicine. Do what is appropriate at that time. The other thing is, patients, used to come in the hospital and want to come in for maybe a blood transfusion or come in for this, rest up a few days. Right now what we want to do is get patients in, treat them for whatever condition that is, and get them out of the hospital as soon as possible. And you say, well, why is that? The hospital, it should be safe. Again, like I told you earlier, no matter how hard we try, things can happen in the hospital. You can get that wrong medicine. Something can happen to you. So what we want to do is get you in, treat you for that condition, find out where you need to go afterwards, make sure there's good follow-up care, but get you out of that hospital as soon as possible. And that's what we're shooting for.
Well, it's obvious you're very devoted to your work, and I want you to continue doing your best and look forward to seeing you again here on the show.
And it's over?
It's over. So thank you so much for coming.
Thank you for inviting me.
Thank you.
Appreciate it, Dr. Robinson. Thank you a lot.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.